Welcome to the University of Virginia's Medical Center Hour. I'm Marcia Day Childress from the School of Medicine's Center for Health Humanities and Ethics. Our center produces Medical Center Hour, which today embarks on a new season, our 50th. For a half century now, this hour at midday in midweek has hosted rigorous conversations on current matters of common concern to medicine, healthcare, and society. From its founding, Medical Center Hour has welcomed everyone at the University of Virginia and also the public. Here, science and society meet, clinic and community converse, town and gown come together, professional pathways intersect. And now, amid the ongoing global coronavirus pandemic, Medical Center Hour moves to Zoom. We debut today as a free weekly webinar, which anyone may join via Zoom from anywhere. In our Zoom format, we provide limited information and resources on a pre-recorded rotation of slides that preceded the program. Please go to our center's website for references, our presenters' bios, information for clinicians about continuing education credit, and a link to the program recordings on YouTube. Today's program is being recorded and closed captioned. Our website also carries our full fall schedule. You might want to make us your Wednesday virtual lunch date. While spirited Q&A has been a Medical Center Hour hallmark, Zooming means that questions and comments from you, our audience, should be entered into Zoom's Q&A function, which we'll monitor and draw from for our speakers' consideration at the end of the hour. It's not optimal having audience microphones muted during the webinar, but we value your views as much as ever. So please do use Zoom's Q&A capability to raise your questions. Today's program asks, should a trauma-informed approach to care be our standard of care? Landmark research from 1998 showed that adverse childhood experiences, known as ACEs, increase persons' risks to health and well-being across the lifespan. Toxic stress due to ACEs contributes to chronic disease, and it increases morbidity and mortality. While ACE prevention is a societal community-based challenge, today we explore practical strategies that clinicians and healthcare organizations can use with patients, families, and communities to screen for ACEs and prevent or reduce their harms. We have three panelists. Sara Robinson directs child and family outpatient and crisis services with Region 10 Community Services Board here in Charlottesville. She'll describe ACEs and explain trauma-informed care. Dr. Paige Perriello, a pediatrician with Pediatric Associates of Charlottesville, will share her own discoveries around ACE screening and trauma-informed care in her practice. UVA medical student and generalist scholar Abby Halm will look toward her future practice when trauma-informed care may be the standard of care. None of our speakers had any conflicts of interest to disclose. We're partnering today with the Medical School's Generalist Scholars Program, which is observing Primary Care Week here at UVA, and with the community-based initiative Welcoming Greater Charlottesville 2020. We also owe thanks for funding to the School of Medicine's John F. Anderson Memorial Lectureship, created by alumnus Dr. John Anderson, whose gift keeps on giving. And now, should a trauma-informed approach to care be our standard of care? And we'll start with Sara Robinson. Welcome, Sara.
Thank you so much. Let's see here. I'm going to go ahead and share my screen. I'm so delighted to be able to talk about this topic with this particular audience today, because I think that this is an audience that it really has the capacity to take this information and use it to have an incredible impact on our community and the patients that we serve. And so I'm going to present a lot of information today to hopefully make a very strong argument that the answer is yes. We should be using trauma-informed care as a standard of practice. So first, what are we talking about when we talk about trauma in the trauma-informed? And I know in the medical profession, often trauma can be a head trauma or the trauma unit, or that was a particularly traumatic day at work. We use that word quite often to talk about an event that has that overwhelms our capacity to cope with that stressor. And that's what trauma is. But when we talk about trauma-informed practice or care, what we're very specifically talking about are adverse childhood experiences. And I'm going to talk a little bit more about what they are and why they matter in around the long-term care that we provide, not just children, but also adults and their lifelong health outcomes. And so it's a very specific type of adversity and toxic stress that create the traumas that we're going to talk about today. And so first of all, where did this idea of adverse childhood experiences come from? Many of you have probably heard of the ACE study. It took place in the late 90s in San Diego. Dr. Robert Anda was an epidemiologist for the CDC, and he was looking at cigarette smoking and the connection with depression. People who had depression were more likely to smoke cigarettes and have a harder time stopping smoking. And Dr. Vincent Felitti was a physician working for Kaiser Permanente out in San Diego, and he was in the clinic that was looking at obesity. And specifically, he kind of was wondering why people who came into the clinic and would lose a lot of weight tended to gain it all back. And he stumbled upon a hypothesis very accidentally. He was asking someone their health history and said, you know, at what weight were you as a child and what weight were you when you came into this program? And he accidentally said, what weight were you when you first became sexually active? He didn't mean to ask that question, but a participant said 4 or 40 pounds. And he said, sorry, I asked that wrong. She said, no, I was 4 and it was my father. And he started to ask about childhood sexual abuse and found that over 50% of the participants in his obesity study reported childhood sexual abuse. So Dr. Anda and Dr. Felitti came together and said, well, what do we know about these early experiences and long-term health risk factors, such as cigarette smoking or overeating? The population that they looked at was a pretty huge survey for research, looking at over 17,000 volunteers that were primarily white, middle class, college educated, 100% had jobs because they had Kaiser Permanente insurance who was supporting this, this study. And so they all had access to preventative health care. And that's really important because we think if you look at this population, you might say they're very well protected against adversity in childhood. We know that's not true based on what the outcome of this study showed us. But it's also really important to reflect on that population versus the population that many of us serve that might not have the economic or education or health benefits of this particular population. And so what their study looked to answer the question, how do these early experiences impact long-term health outcomes? And the answer was very negatively. So in looking at the original study, and I'm going to say this a few times because it's so very important. In the original ACE study, that population I just discussed, there were 10 ACEs. So 10 things that if you had experienced these prior to age 18, then you're more likely to have negative health outcomes in your life later on. And they were generally in the categories of abuse, physical, emotional, sexual, neglect, physical or emotional, or what they called household dysfunction. So living in a home with a caregiver or a parent who had mental illness, a substance use disorder, was incarcerated, witnessing a mother being treated violently. In the original study, it was just looked at mothers and domestic violence, or having parents who are divorced or separated. And of course, you can see they sort of calculated an ACE score, and that's how they were then able to use this data to make sense of these long-term health outcomes. So here's what they found. First of all, ACEs are incredibly common. 2 out of 3 of the general population report having experienced 1 or more ACEs by age 18. And we also know they tend to cluster. So someone who reports having 1 ACE has an 87% chance of reporting more than 1 ACE. And you can kind of take a look here at how prevalent some of those different ACEs are in that well-protected population. So if you start to think about populations that are less protected, or maybe have more poverty or environmental consequences, you might start to think, gosh, that might look a lot higher. And actually, we know in the helping profession, that number is higher than 2/3, because people who've had hard times tend to want to help others, I think. It's my hypothesis. But the ACEs really have what's called this dose-response relationship, where the higher the ACEs you've experienced, the greater the percentage of health problems that you could experience over the course of a lifetime. Now, of course, ACE scores are really good at predicting group health outcomes. They're terrible at predicting an individual's health outcomes. We'll talk more about that in a minute. But what we know is that ACEs reliably predict those negative health outcomes across the life course. Things that you might actually not be so surprised about is that if you've had a lot of trauma growing up, you might be more likely to adopt those health risk behaviors that I think of as unhealthy coping skills, things like substance use, overeating, drug use, smoking. But what I believe was more surprising is that there are over 60 other health outcomes that also increased as your ACEs increase. Things like heart disease, cancer, stroke, obesity, diabetes, things that might be a little bit surprising to think about the connection between early experiences and those health problems later on in life. I don't expect folks to study all of these graphs. I really put it there just to show that dose-response relationship across this huge spectrum of health outcomes that we start to say, whoa, this is important because it's telling us something about our health and risk factors for poor health. And it's really important because what's predictable is preventable. So it starts to become something that we think about, not just in the medical profession, but in so many different silos that we tend to function in. So this slide is a risk attributable graph. We call it the oil slick because you see that here in the middle, this image here that looks sort of like an oil slick. That is the percentage of those health or social problems that are directly attributable to ACEs. And so we start to look at this and think about how in our communities, we often, again, we stay in our silos. So for example, the mental health professions might be really interested in suicide attempts, depression, mental illness. The medical profession might be really interested in asthma and insulin diabetes, HIV risk. The criminal justice system, looking at incarceration rates, drinking and driving, IV drug use. We tend to stay in our lane in social services and the school systems. But what we know from the ACE study is that ACEs are the thing that connects us all. And what if we were to reduce or prevent ACEs? Imagine what it would do to those percentages. That oil slick might really be absorbed in a way that we could reduce endless health and societal problems that we all struggle with in our professions. So it's really powerful information. Now, the reason I was mentioning the idea of the original 10 ACEs is because in the past 20 years, the ACE study has been replicated over 50 times. And what those subsequent studies that were done in other communities that maybe weren't didn't look like San Diego in the late 90s, but maybe had a different racial or ethnic or cultural or socioeconomic makeup, those studies have taught us is that there are so many other experiences children can have that lead to toxic stress. Things like racism. And I'm going to talk a little bit more about that later. But we know that the exposure to racism has a physiological impact on the body. Poverty, of course, not just witnessing a mother being treated poorly, but also a sibling or the father, witnessing community violence outside of the home in an unsafe neighborhood, being bullied by peers or adults. Any involvement in the foster care system is a trauma to children. And then, of course, in San Diego in the 90s, they weren't living in a war zone, but we can easily recognize that as an ACE. And if we think of the news coverage in the past couple years and seeing children who are locked up in cages and losing their members to deportation, that is an adverse childhood experience, and we understand it to create toxic stress in the body and potentially impact the long-term health of those children. So you can kind of take a look at what those experiences here might be within the home environment or the family environment, but also the community environment and the access and the resources that children and families have to do well or not. So what does the exposure to ACEs do to the brain? This is so important when we think about the long-term impact on health. First of all, just to remind everyone how the brain develops from the bottom up and the back to the front, we know that the brain stem from birth is functioning for survival to keep us alive. We're breathing and blinking, and our heart rate, everything, our brainstem is keeping us alive. It also keeps us alive through that survival response to threat, fight, flight, freeze, etc. And so when we're in our survival brain, we're really seeking safety. That is what we need. But in that moment, we really have very few choices about how we behave. And of course, the limbic system, where you have your amygdala and your hippocampus, your fear and worry center, and your short-term memory, is really where your emotional brain. And when you're in your emotional brain, you're seeking connection. That's what your brain needs. And of course, over time, as you grow and develop into your 20s, maybe almost to your 30s, your prefrontal cortex is wiring and developing, where you have all your executive functioning, the ability to attend and plan and be able to communicate or problem solve. And most importantly, that's the learning brain, where you're able to learn new information or skills. And so as we think about how that brain develops over time, that is the predictable, that's sort of the typical development we might expect. But what happens when you experience or the exposure to ACEs? Well, quite simply, it disrupts that development, in that how the brain gets developed, that neuroplasticity. Every time you have an experience, a neuron fires in your brain, and if in the beginning you're going down that, to get down that pathway with a new experience, it's like a slow country road. It's hard to get down. But every time you have that experience, that pathway in your brain, it increases and grows and develops until that pathway becomes like a super highway. You wire your brain to be able to do something very, very quickly without even having to think about it. And so ACEs impact the brain in that if you live in an environment or have a childhood that is unsafe, then what your brain gets wired to do really, really well, the super highway of your brain, becomes fight, flight, or freeze. And you're not necessarily spending the time wiring your executive functioning brain the way you need to for things like self-regulation or problem solving, decision-making skills, the ability to be in healthy relationship. So we understand that the brain's development, the architecture of the brain can change through the repeated exposure to toxic stress and to that survival, the need for survival. Another way that that exposure changes how the brain functions is through some really interesting research that tells us that depending on your age, gender, and the type of maltreatment you experience can impact different sensitive periods, can impact different parts of your brain during sensitive periods when those structures of your brain are particularly vulnerable to toxic stress. And we understand that when you're in fight, flight, or freeze, when you're in your survival brain, your body floods with adrenaline and cortisol. And cortisol can be toxic to your body and their systems, but also to different vulnerable parts of your brain. And I just put one example. So the corpus callosum, we know that we need this bridge between the two hemispheres of the brain. But the corpus callosum has a sensitive period. So if you're a male who experiences neglect, age 0 to 3, or a female who experiences sexual abuse, age 8 to 10, those are two sensitive periods for the corpus callosum. And it could actually damage or change the structures of your brain so that later in life, when you need to, you might not be able to integrate information in the two hemispheres of your brain. And I think that we see often, we can't see inside someone's brain to know if there has been an injury, right? We can't open up someone's head and say, maybe that structure is not working the way that it needs to. But what we can see are behaviors, and we start to change how we think about those behaviors. Obviously, that cortisol that I was talking about has a negative impact on the body as well. We have cortisol flood through our bodies long enough. Let's say if we're a caveman, it's long enough for us to run from a bear or fight a bear or hold really, really still and hope the bear goes away. But in our everyday life, we rarely get to run or fight and use up all that cortisol. What it does is it builds up in our body and it can damage. Cortisol is a toxic stress hormone that can damage many of our different systems in our body and lead to things like heart disease or diabetes later on in life. The wear and tear of that allostatic load. We start to understand if you're a child who has had tremendous toxic stress hormones build up in your body, your long-term health impact will be negative. And of course, epigenetics is one more way that exposure to ACEs changes what happens in the body. And so importantly here, changes not just your long-term health impact or outcomes, but also that of your children and the next generation. And that research tells us that, it's research around rats that taught us that exposure to rats being shocked when they smell a sweet smell of cherry blossoms can eventually lead them to have a negative response to the smell of cherry blossoms when they're not being shocked. But what they found is that when those rats went on to have pups, little baby rats, those rats also experienced the fear center of their brain light up when they were exposed to that smell, even if they had never had an electrical shock. Because what happened is in the epigenome around their DNA, certain switches and tags got turned on and off that changed how they experienced that smell. And so we start to think about historical trauma or intergenerational trauma. What are you born with, wired into your DNA, and how it gets expressed? And I think about that particularly in Charlottesville, when we have 400 years of violence and discrimination towards Black bodies in our community. What has that done to how their bodies have been able to manage stress and the toxic stress of that violence and what gets passed on? So to sum up the ACE study, we think about, well, what are you born with historically? And then what community or social context are you born into? So sort of that's your starting point. And then when you have exposure to ACEs, how does it change your body and your brain And what does that then mean for if you experience impairment? That might lead to you adapting those unhealthy coping skills that lead to disease or disability, or social problems like incarceration or unemployment. And potentially early death. One of the more frightening statistics that came out of the ACE study is for a person who has an ACE score of 6 or more, on average, their life expectancy is 19 years less than a person who has an ACE score of 0. That's a huge number when we're talking about life expectancy. And so I said I would come back briefly to racism, because once you understand all those many different ways that toxic stress and adversity impacts the body and changes those long-term health outcomes, I think it's a no-brainer that we can't talk about trauma-informed without talking about being anti-racist. And we have to include this in our conversation. And again, it wasn't in the original 10 ACEs, but we know that racism changes how the body and the brain is able to function well. It can change, I should say. And so we understand also that our systems are set up to perpetuate that type of violence against Black and brown bodies. And how do we start to include that in our trauma-informed best practice? Now, very important is back to the idea when I changed my language to it can cause those changes. Because when I was talking about ACEs predicting group health outcomes, but that they're terrible at individual health outcomes, the reason is that the 3 E's of trauma. So the actual event of trauma, the thing that happens may occur, but the individual's experience of that event may be very different than someone else because of their individual's resources, resilience, access to supports, previous life experiences, previous traumas, or individual skills. So you can have 2 people who are at the very same traumatic event, but their individual experience of it could be very, very different. And that means the effects on those individuals will look very different. That's why you can have a person with an ACE score of 1 who's really, really struggling, or someone who has an ACE score of 9 or 10, like for example, Oprah Winfrey, and she's doing all right. So we start to understand that you cannot look at someone's ACE score and know how it's going to impact them because you're not calculating in their resilience score. And what does it mean? What access and supports do they have to do well? So when someone comes up to me and says, I have a really high ACE score, I say, well, then that just means you have a risk factor, not unlike having a family history of diabetes. And you need to take really good care of yourself. Why do we even need to ask about this? And this gets into screening. And I've just put an example of how, someone could come to the doctor and describe these symptoms here in the middle, saying, I'm really having a hard time with concentration and sleep, and I'm disorganized. And we might say, oh, well, you must have ADHD and we need to prescribe a stimulant medication. But if you're not asking about lived experience, you may be missing the mark, because those are all symptoms of trauma as well. And of course, you can have both trauma and ADHD, but if we're not asking the questions, well, we can't treat trauma with a stimulant medication. And so just a reminder that we would never use the original 10 ACEs to screen for ACEs, because a person could say, I have an ACE score of 0 based on those, but having lived in a community with violence and exposure to racism every day and poverty, that's a 3, and we understand we need to include more adverse childhood experiences to really capture the lived experience of our patients. So what do we do about it? This is the question that we really need to move into. We know this information, the research tells us that this needs our attention for the long-term health outcomes of our communities. Well, the first thing is it really changes our lens on how we view both behaviors and also how we view symptoms when we're looking diagnostically. So we start to think about, it's not just well, what's wrong with that person, but really what's happened to them? How did it impact their brain or their body? And how can we best help and build their resilience? Or what supports do they already have? And strengths do they already have? We need to start thinking about preventing future ACEs, reducing the dose for people who are exposed to them already, or offering better treatment to people, trauma-informed treatment. And I will come back to this every time I talk about ACEs, is we cannot take care of children if we do not take better care of their caregivers, their parents and caregivers and teachers and health providers. And I think that is really true, particularly around looking at ourselves and our colleagues. This is information about us and our families as well. It's not just about others, because we experience adversity as well. And so how do we take care of ourselves, particularly in the face of secondary trauma or vicarious trauma? And so we are starting to really imagine, how do we, I love this idea, how do we treat the well if that's what's causing so many of the symptoms that we may be seeing? And we know, I put this slide, we know that resilience, you can have high ACEs, but if you have more supports and resources and access to the things you need to do well, you will do okay. And I like this slide particularly because I want to highlight a doctor you trust is a factor of resiliency. And the number one recommendation is always going to be relationship, relationship, relationship. That is how we heal trauma. And it is not enough just to look at individual skill building, but we know that we need a community to wrap around our individuals to teach and model those skills and to show up with support and resources. And just so important, when we think about trauma-informed interventions, those interventions must be culturally and contextually relevant to that individual to be impactful. That is what the research tells us. And I think that really involves empowering patients to be able to say what would be helpful to them. So trauma-informed care, should it be the standard of care? I hope I have made a strong argument for absolutely yes, because we know that people who actually, this is really great research, people who have higher ACE scores, but also report high quality support in their lives and hope for the future, have better long-term health outcomes than people who have no ACE score and low support or low hope. And so we really can positively impact the long-term health through our trauma-informed practices. And one way that we do that is we recognize all behaviors are communication. And what they're communicating is exactly what part of someone's brain is firing in any given moment. Are they seeking safety because they're in their survival brain? Are they seeking connection when they're emotional? Or are they ready to learn and problem solve because they're in their learning executive functioning brain? And if we start to view behavior as communicating that, then we're really able to offer the thing that they need in that moment to do well. So to kind of summarize, trauma-informed, it's keeping people safe and connected so they can learn. And we see difficult behaviors arise when people don't have the skills they need to solve the problem in any other way. And so that is where our relationship with them can really make a huge impact. So thank you very much.
Hi, everybody. Can everyone hear me? Somebody give me a thumbs up. Okay, great. I'm Paige Perriello. I'm absolutely thrilled to be here to add on to the presentation. I'm always grateful to be with Sara Robinson, who's taught me almost everything that I know about trauma, to give a little bit of a practical case study of putting this into action. So I'm going to tell you a little bit about how I answered the question that Marcia asked with a big yes, that I thought that trauma-informed care was an important way to move forward, and tell you a little bit about how we did that at my practice. I would like to start and just acknowledge that my privilege as a white physician in this space is important, and it obviously impacts the way that I tell the story and the process that we've been through that is not afforded to my Black and brown colleagues, and I always like to acknowledge that. So I grew up here in Charlottesville and moved back to town about 12 years ago to join Pediatric Associates as a general pediatrician. We're a large independent practice that's been around for about 50 years. In fact, was started by my father and some other pediatricians. And so the multi-generational aspect of care that Sara was referencing is something that I get to experience every day. And one of the important factors to my dad when he started the practice, and one of the things that really brought me back to join, was this idea of providing really complete, comprehensive care to our patients. And I think we've done that very well for a long time. And some of the things that we thought really helped to reach out to families was to be present. So we're open 7 days a week. We're always open till 9 o'clock at night. We've always had some other services in our practice, like psychologists and some other aspects. And so things seem to be going along pretty well. But all of that changed fairly radically for me. And I found a missing piece after the summer of 2017 here in Charlottesville. And as everybody knows, there was a series of rallies by white supremacists and hateful groups marching through the streets of Charlottesville. And as I left the streets on Saturday, August 12th, and 2 days later, Monday morning, walked back into my office, which is a mere 5 or 6 blocks from where the white supremacists had marched, I understood that the status quo was not good enough, and that I wanted to look for a new approach for understanding that the most important thing about how we meet and greet families at our office is that they feel they're coming to a safe and supported environment. And I was fortunate enough about a month after August 12th to have a recommendation from a friend to read Dr. Nadine Burke-Harris's book, The Deepest Well, which is a must read for anybody who's interested in this work. She essentially brings into pediatrics all of the science that Sara just shared with us. From the initial ACEs study with some very powerful stories. And so I knew I had my framework. I knew that trauma-informed care was a missing link in how to be sure that we were protecting and serving our patients in all of their health needs. So in the fall of that year, I enthusiastically took this idea to my colleagues and partners, not having necessarily thought through all of the aspects of it. We have some really amazing opportunities in primary care for, particularly in pediatrics, for having a trauma-informed approach. We're lucky enough to know families often from sometimes even before they have a baby, all the way through till they're 23, 24, sometimes 25. And so they get to know us very well. Our office is very familiar. We take care of physical and mental health and do a lot of parent education from the beginning. We become familiar with each other. As I said, we're working on the trusted and safe place for all families to be sure that we are. And so we're a natural place to look for ACEs and to look for trauma and to have this trauma-informed approach. There are, of course, barriers, and in that very first meeting in the fall of 2017, my colleagues helped point them out to me and emphasize some ways that we needed to focus on these. First of all, many of us are not taught anything about ACEs or about this science in medical school and afterwards, and so the first barrier is just knowing about it. Time is always a factor, particularly for primary care providers. We have a lot of burdens on our plate to cover, and so having one more thing seems like a lot. And then the next ideas are really important. And Dr. Amanda Jones, who is my colleague and has been just a force on this project with me, and I thought a lot about this at the beginning, which is, what do you do with the information? You screen somebody, you get this information, what are you gonna do with it? And so there's a lot of fear about what what are we going to do? How prepared are we for it? And I'll address that as I talk about our project. Thankfully, I was able to stumble upon, just in time to apply, out of the Greater Charlottesville Trauma-Informed Community Network under the wise leadership of Alicia Lanahan here in town, doing a project where multiple groups, not all medical groups, but groups across the community could apply for to be a trauma-informed leadership team, to basically look at your organization, look at other organizations in town, and find out how you can move towards a trauma-informed approach. And so we were really lucky enough to get included in this. Don't worry, we're not going to study all these, but Traumatic Child Network has these sort of domains that they've put forward. So they're giving you a little bit of a roadmap, which they gave us in these 7 things to look at in terms of how you could start to become a trauma-informed practice. We were encouraged at our first meeting to pick 1 or 2 of these to work on for the year. We picked 3. So these are the areas that we decided we wanted to focus on. We wanted to look at screening, we wanted to look at resources and referrals, and we wanted to talk about vicarious trauma. So I'm going to really take you through a sprint course of our year here with each of these categories and what we did. So the first thing that Dr. Jones and I decided we really wanted to focus on is we needed some type of universal screening for trauma or ACEs. Sara thankfully walked you through a number of the reasons why the ACE screening itself, the original ACE screening, was not necessarily the best choice for us. We figured out pretty early on that's not really what we wanted to do. One of the things that drove us to this work were some of the ACEs like poverty and racism and some of the other things that are not included in those initial studies. And so we figured out pretty early we didn't want to use that screening and looked at a number of different screenings. There aren't really any validated screening for this. As everybody in primary care knows, many of them were 2 pages, 3 pages, 40 questions, things that were just not practical for us to be able to do. And often they were very focused on specific traumas, and we really wanted to cast a wide net. And we learned that thinking about social determinants of health was a really important way for us to get at that. And social determinants of health are just the conditions in places where people live and learn and work and play that impact their health outcomes. And so our goal for screening was to develop a generalized and short questionnaire whose primary purpose would be to open up conversation and allow people to feel safe and supported and bringing things up that might be important and impactful to their health. So here's our tool. After a year or so and lots of help from Sara Robinson and the TILT team, we had a goal of 5 questions. We ended up with 7, so we were pretty happy with that. And this covers a wide amount of topics, from who lives with parents, about violence in the home, food insecurity, housing insecurity, which has become a huge issue over the last couple of years, behavior changes, racism and health, and then a question I want to highlight that I'll come back to at the end, which is, has anything really scary or upsetting happened to you, your child, or anyone in your family since you saw us last? And so this is the screening that we're using to start these conversations in our office. The second domain, and I'm sorry I have to go through these kind of quickly, but the second domain that we looked at was resource coordination and referrals. And as Sara pointed out, we are so lucky in Charlottesville. We have so many organizations, community groups, and individuals doing really amazing work. But often those works are in silos, and we don't have a lot of bridges between those important groups. And for us as pediatricians, one of the most important things we can do is help build those bridges for families to the resources they need. So we wanted to look at exploring what resources existed, find some community partners we could work with, build those bridges to our families, and possibly most importantly, we really wanted to coordinate that with our questionnaire. And so here is an example of one of the resource sheets, and they exist for each of our questions, so that any yes screening, our patients can automatically leave with something in addition to our conversation. So each of the sheets has a few tips. Maybe we had time to go over that in the visit as part of the yes screening, but a couple of concrete tips that they can leave with, as well as some of the local resources here in Charlottesville with numbers and hours where relevant, so that we could really build that bridge and make that connection. The last domain we chose to work on, and here is the TILT team here at my office, was Vicarious Trauma. And if this was important 3 years ago when we did this, it's escalated in importance at this point, with COVID disease certainly having increased a lot of trauma in the medical environment. We worked a lot on training of our staff and other providers to be sure that they were updated on ACEs and trauma and why we were doing this. And one of the things we really wanted to do was also provide a place for our staff where they could go if they needed a minute. Maybe they'd been triggered by a trauma themselves. Maybe they were having a tough moment. Maybe you heard a really hard story and you needed a minute. And so based on a concept we found at one of the trauma conferences we went to, we created a Zen Den. There's a couple pictures of the Zen Den. So a place, and of course, we made sure that supervisors knew about this and were supportive of its use, to take a couple minutes to draw, squeeze a ball, work a Rubik's Cube, sit, and kind of get through that. So I wanted to cover a few lessons learned from a really quick run through those 3 domains. The first is, and I'll cover this again in just a minute, is to just get started. So that is kind of what I did with that initial meeting to my colleagues when I hadn't really necessarily thought through all the details, but we really want to find some steps that you can do right away to be moving in this direction, because you learn a lot from each part that you do. The second thing we learned is don't forget resilience. And Sara talked beautifully about this at the end of her presentation. In our first presentation that we gave to our staff, we were so inspired by this research we had learned. We really wanted to be sure everybody in our staff understood what we were talking about, the science, how they might recognize some of those behaviors in our patients. And resilience, and some people really like that word and some people don't like it much, but essentially what it's standing for is this idea that you can counterbalance trauma, as Sara was talking about, with positive, healthy relationships and behaviors that can help counterbalance the impact of the trauma. And the resilience in our first staff meeting got about this much time, and the ACEs got about this much time. And so we did trigger some of our staff members who spent the presentation counting up their ACEs and wondering at the end if they were sort of doomed and their children were doomed. And so we learned a lot about how to present that information from that first meeting. One of the most important things for pediatricians, and one of the biggest reasons Dr. Jones and I really just got behind this idea of trauma-informed care, is these behavior visits that Sara started to talk about. As pediatricians, there's not a day that goes by where we don't have a school problem or a behavior visit on our schedule. And it really has helped to reshape how we look at those visits. Every kid who presents to us with a behavior visit does not have ADHD or oppositional defiant. We really need to think about what that child's behavior is telling us about what they need. How is the parent's response to that behavior telling us about what they need or what skills they may need to have an increase in? And always, again, in every trauma training that you go to, you are trained to start thinking about what has happened to that child, not what is wrong with that child. And that really turns everything around in terms of how we look at it. And then, of course, is to get your colleagues and the leadership of your organization on board. I've had an incredibly supportive group, both the TILT team that we worked together, but also the whole office has really embraced this, which has been really important. I wanted to talk about this work is of course not done. So we have a lot of ongoing projects that I wanted to tell you about. So first is that one of the hardest questions to write and one of the most difficult sheets to try to come up with our families has to do with racial trauma. We really want to be proactive about looking for what are the best ways to ask children and families about racial trauma, how that's impacting them, and what kind of resource connections work for them. And so I am working on a grant through the American Academy of Pediatrics to look at that right now in our community. My office is involved in a national AAP project that is around social determinants of health in younger aged children. And we are hoping through this project to actually validate our screener so that we can share it a little bit more widely. So that would be really exciting. We have ongoing efforts to educate our staff, providers, and to get actually our patients involved and our families involved in providing valuable information for us, and then continuing to work on our community partnerships. We have been fortunate to come out of this project with really strong relationships with Sara Robinson and Ready Kids, with Wild Rock, and Region 10, sorry, Sara Robinson and Region 10, and Ready Kids and Wild Rock. We had a really exciting trauma play group that was getting ready to launch in April of 2020, and that will be continued when we're able to do it safely, to try to bridge some gaps on the waiting lists for young kids who need trauma therapy, but our waiting lists are long, to do some outdoor play with the group from Wild Rock. And additionally, Boston Medical Center has an incredible program called Health Equity Rounds, which helps highlight how issues of health disparity impact a case. And I'm gonna be working on bringing that here. So the last thing I wanted to leave you with is just what can you do today? What can you leave here and start doing now? And I know this is Primary Care Week with a focus with our generalist scholars. So the first thing I did on that Monday after August 12th when I walked into my office was I parked right in front where the patients park. I walked in the front door. I sat in the waiting room. I walked all around the office. I watched the interactions, looking for everything about how you would feel as a patient coming into our office. And that's a really important step you can do immediately. What's on the walls? How are people acting with each other? How does the interaction happen? Where do you ask patients about billing and their information? Do you do it in front of other people? So things like that. Continuing to educate yourself. We're working on a book club. I know everyone will want to sign up for that, but a good way to get together with colleagues. If you can't handle a book, you can try a chapter. If you can't do a chapter, there's Nadine Burke-Harris has an amazing TED Talk that's 20 minutes, which is always a great first start. Continue to educate others in your office, and then ask and listen. So when Amanda and I first started this, before we had our questionnaire all lined up, we asked this one question. We just started doing it, and it was really scary at first, this question about anything scary or upsetting happening. And it was really remarkable. At the end of every week, we had a story for each other. And it was amazing both what families were willing to share with that question, and also that sometimes just acknowledging it and talking about it is part of the problem. We didn't need to have everything figured out that first day, but giving the families an opportunity to talk about the trauma that had happened and offering them support was a great first step. I also really encourage, especially white providers, to read about the history of systemic racism in medicine. I recommend Medical Apartheid by Harriet Washington, which is an incredible book that we all need to read to understand how our Black and Brown families are coming to our offices and what we can do to help them feel safe and trusted. And then of course, remembering always to take care of yourself and staff and have check-ins when you're talking about difficult topics. Ooh.
Thank you, Sara and Paige, for your thoughtful and informative remarks. I'm so moved and inspired by the work you're doing to both provide and teach this model of trauma-informed care. And as a medical student, I'm grateful for the opportunity to absorb and ultimately act upon this knowledge. So thank you both. My own path to medical school was not linear. And in fact, 3 years into an undergraduate degree in economics, I had never once considered a career in medicine. However, 2 months into my junior year, an angry appendix served as a catalyst for conversations with a surgical resident that entirely reoriented my future plans towards a path that ultimately led me to medical school. Rather than simply treating what was certainly a routine case of appendicitis, the resident on my surgical team expressed interest in understanding each of my concerns and situational worries. She made me feel like she was on my team, and I trusted her as that captain. I never expected that what started as an inflamed appendix would spark my interest in learning individual people's stories and in having the privilege of partnering with them in their healthcare. But this is how I chose a career in medicine. And now in my second year of medical school, I am grateful for each conversation with a patient, each story from a lecturer, or each time spent volunteering at a health organization that challenges and expands my understanding of the way one's own communities and life experiences, that is, how each one's story influences her health and experiences with healthcare. Trauma-informed care seems to me a practice of learning someone's story and appreciating and acting on how each of its factors and players, the variables in that person's world, influence a patient's health, that is, the outcome. In preparation for today's program, I read the book that both Sara and Paige have already mentioned, Dr. Nadine Burke-Harris's The Deepest Well. Through sharing both powerful individual patient stories and peer-reviewed scientific research, Dr. Harris provides compelling evidence for the link between an individual's ACE score and his future health risks and outcomes. I find this association between ACE scores and health to be, on the one hand, incredibly sobering. It provides yet another frustrating example of how experiences we have no control over can have a dramatic and long-lasting impact on our health. On the other hand, the science behind what seems an intuitive link also gives me some hope regarding the ways that this realization gives us evidence-based reasons to search for and factor in additional pieces of each patient's story and arrange for that person's care and support to be tailored to their particular needs. And in this way, I am heartened by the possibility of the improved patient care that this approach and its additional clarity can provide. Looking ahead to my future practice, I trust that screening for ACEs will be common practice so that each patient's story will be heard and understood as a real and important influencer for health. I trust too that my practice will be organized in a way that assures patients of the resources and support they need to be as healthy as they can be, now and in the years to come. I hope that, as a practitioner, I'll continue to grow in my appreciation for the ways in which our histories influence our behaviors, our access to safety and security of food and shelter, our responses to stress, and our trust in and relationships with others, including healthcare professionals. I believe that we as individuals are not the sum of siloed parts, but rather a rich web of intricately yet imperfectly blended stories and experiences. I imagine a model of care that understands and respects individuals in this way, a world in which individualized care includes the curating of each patient's team, to include physicians, nurses, mental health providers, social workers, community advocates, and partners, etc., who together connect with an individual and nurture their health and personhood. I can imagine that in this model, an ACE score will not only serve as a means of flagging risks, but also as a tool for informing and building this team of individuals who will partner with a patient in caring for her health and well-being.
Thank you all. We've packed a lot into an hour and we're very close to the end time. I will let you all know there were 3 questions, one of which was answered in the course of the presentations. Another question I can answer right now, and that was, would the slides be provided after the program? And my understanding is the program recording, which will be posted to our centers or to the Medical Center Hours YouTube channel, UVA MCH, and should be posted there, I think, within about a week. The slides will be visible there as an integral part of the presentation. The third question had to do with whether in the Pediatric Associates practice, do you screen for handguns in the home? And just very quickly, yes or no?
Not as part of our trauma screening, but in general we do, yes.
Great, thank you. Also, I just in wrapping up, say that, you know, this is a remarkable field with a wealth of resources, and we could only touch the surface today, get you to start thinking about, looking at, and beginning to plan perhaps for how to adjust an established practice or how to start a new practice that takes a trauma-informed approach. There were, I think, some great tips here, including Paige's thought of carefully considering how you arrange your office. And also the use within the practice of the health professionals of sharing stories of their own experiences in the course of a work week as part of their own self-care and resilience. Again, we are out of time, but I would invite you to please join us for next week's Medical Center Hour, which is called Pandemics, Epidemics, and History. Where are we now? That may be a question we ask ourselves every day. Our speaker is UVA Professor of History, Christian McMillan, PhD, who is author of a small book, but rich, Pandemics, A Very Short Introduction. So we will see you next Wednesday, 23rd of September. Thank you all for being with us today. Thanks to our three speakers, Sara, Paige, and Abby, for making our Zoom debut such a rich and wonderful program. Thank you and see you next week.